We can go ahead and get started. It's the top of the hour. Thank you everyone for joining us today for this webinar on best practices in GME technical assistance. Today we'll have Dr. Emily Hawes, Lori Rodefeld, and Dr. Richard LaBaere joining us for this presentation. Emily Hawes is the director of the SHEPS GME Technical Assistance Center and a professor in the Department of Family Medicine at UNC Chapel Hill. Lori Rodefeld is the Deputy Director of the SHEPS GME Technical Assistance Center and the Director of Rural GME Development at the Wisconsin Collaborative for Rural Graduate Medical Education. And Dr. Richard LaBaere is the Director of the Missouri GME Technical Assistance Center, as well as the Associate Dean for GME at the A.T. Still University Kirksville College of Osteopathic Medicine and DIO for Still Osteopathic Postdoctoral Training Institution. Here are our disclosures, which we welcome you to read later on. And we also would like to say thank you to our research collaborators who help make this work possible. And at this point, I'm going to turn it over to our presenters.
Wonderful. Thank you, McKenna and team. Like McKenna said, my name is Emily Hawes, and really wanted to share with you, start us off by sharing why we've had this ad hoc short notice presentation. And a large part of it is that we have seen that many states are incorporating graduate medical education into their rural health transformation plan and have been asked to really share about the importance of technical assistance as you're establishing new GME programs. And so we have many lessons learned through our work running two federal centers supporting rural residencies and teaching health centers through the Rural Residency Planning and Development Program, as well as the Teaching Health Center Planning and Development Program, as well as done quite a bit of research on what different states are doing to address rural physician workforce initiatives. And so we're really thrilled today to have Lori Rodefeld with us, who's been living this out in Wisconsin for years, and Dr. Richard LaBaere, who is establishing a brand new technical assistance center in Missouri. So I want to give you the slide and presentation in one slide, just in case you have to hop off and attend a different meeting. So our key takeaways for today are that prioritizing statewide technical assistance with startup funding is a critical component of a GME growth strategy, ensuring programs to expand and importantly remain sustainable long term. Designing programs that will be sustained through stable sources like entitled Medicare reimbursement is really complicated, and it can be impacted by several factors such as hospital type, location, and specialty. And so today we're going to give you some tools that all of you can access through our free kind of portal to really guide you as you're considering kind of establishing TA services across your state and supporting new GME growth in your various respective communities. Partnerships are important to the success of rural GME programs, and we'll illuminate to you some of the partners that, from a financing and research standpoint, seem like strong, viable options from a funding standpoint. But we know what is beautiful about this rural and underserved work that we've been doing for almost 8 years is that each residency is unique because it's designed for each community's needs and based on the beautiful assets of each community. And so we want you to have some guiding principles as you're kind of designing and uniquely implementing GME across your states. And then finally, this is really challenging work, but it has a big impact and can really impact not only the physician workforce, but the health and well-being of your communities long term. So it's worth that hard work. And with that, I'll turn it over to Lori.
Great. Thank you so much, Emily. So she's kind of covered, our presentation in one slide. And, one of the reasons why we're so interested in this work is because this work is complex. Federal funding for GME is very complex and has remained kind of stagnant. And what we're seeing is that states are kind of taking matters into their own hands to address workforce needs. And there's a wonderful article in the upper left that I would encourage you to take a look at if you're interested in learning more. It's lessons learned from state-based efforts efforts to leverage GME. And Emily was one of the authors on this article. It's really a great resource. Our team is also in the process right now of finalizing a Millbank brief that will talk about a roadmap to a comprehensive state GME strategy. We are happy to send that out after this webinar and once it's actually in print to all of you, just as a resource, because there's not a lot of information out there about how to launch an effective state GME strategy, which is why we created this roadmap, if you will. But again, you look at the news, you look at the past year or two, a number of states have really stepped up to help support and fund GME. And in the lower right-hand corner, you'll see Missouri has been really leading the charge, not only in creating a new TA center, but also expanding on program development grants, expansion grants, feasibility studies, and a number of other efforts to grow their workforce. So again, you'll get to hear about that from Rich in a little bit, but we are really excited about this because every state across the country is looking at different ways that they can grow workforce, especially when they look at physicians, because they're hard to recruit, they're hard to train, and then it's important that we retain them. So why invest in a state-based strategy? And our team has done a lot of research in the rural GME space, and we know not only are doctors needed in these areas, but we know that the data demonstrates that those who train in rural and medically high-need areas are more likely to practice and stay in those settings. Retention, you can draw a 100-mile radius around where any resident physician trains, and the majority of those residents will stay in that geographic area. So again, that place-based training really matters. It really makes an impact. And when we can get residents into those settings, we not only expose them to rural training, but we show them that it can be a rewarding and fulfilling career. They can learn from wonderful mentors. They can see themselves living and practicing in that rural community. The number one predictor of future rural practice is participating in a rural residency program. So what is a state-based strategy? Our team has worked with a number of different states, not only actually implementing plans, but also helping states kind of strategize and develop a framework that will make an impact. And when we look at GME strategies, there's really, I think, as Emily already noted, it needs to be collaborative in nature. This is never the project of one particular specialty, one particular academic medical center, one particular state organization. It really needs to be a collaborative approach that kind of transcends all boundaries. It needs to be focused on both growth and sustainability. Launching a new GME program takes time. It takes 3 to 4 years on average, and you want those programs to stay intact and stay successful because it's just absolutely critical. When we look at the elements, that states are employing to really, develop comprehensive approaches, they're kind of covering a number of different things, and we'll focus mostly on the technical assistance piece of this. But states are looking at planning and development. Planning and development grants can range widely from $300,000 to $1 million to launch a new GME program. A number of states have expanded existing programs. A number of states have invested in sustaining existing programs and ensuring that those programs can be effective into the future. They've developed governance structures, advisory structures to help inform their plan. And you'll hear all about technical assistance in just a little bit, but technical assistance is a key element of a successful statewide strategy. They do a lot of data, looking at the workforce analysis, looking at projections, and then also, just importantly, looking at the outcomes, showing what the programs have accomplished, what they're achieving, and how they can be supported so that they can be successful into the future. So again, kind of in summary, state appropriations and Medicaid GME are currently supporting growth. We'll have to add to this slide, Rural Health Transformation Fund will also help support growth of new GME programs. But again, these state appropriations and Medicaid GME together are supporting the development of new residency programs, expanding and sustaining the existing programs, and providing technical assistance to support the growth. And then they're also looking at other innovations to grow workforce in targeted areas. In my state of Wisconsin, we started with some GME development grants, and then that's launched into other health professions. And we've seen some really great outcomes from, expanding our allied health workforce, our APC workforce. And I love this little grow our own equation. We know that if a medical student is from Wisconsin, they attend medical school in Wisconsin, they attend residency in Wisconsin, there's an 86% likelihood that they'll stay. So we call that our 86% equation in Wisconsin. And we know that this model works. We know that focusing on, our own, medical students who have ties to our state is kind of the how we've developed our policy and shaped our overall GME strategy. So what is technical assistance? And, we have seen a variety of different models. In our Millbank brief, we've looked at different technical assistance centers, who's launching that, who's providing that. But again, looking at both our national work and the statewide partners that we've worked with, we've kind of come up with a really great definition of what technical assistance is. And I want to credit Shelby, who's on the call today from our team. She's helped us kind of define technical assistance. It is a structured, evidence-based, informed, partnership-driven system that enables organizations to design, launch, and sustain residency programs. It's responsive to local community assets and needs. It integrates a number of different things, including a readiness or vitality assessment, tailored advice and consultation, peer learning networks, access to resources, sustainable funding, continuous evaluation, disseminating and sharing best practices, and using wonderful tools like roadmaps to help strengthen capacity and grow a workforce. And you will hear about this in much more detail as we share specific examples and as we dig into what TA is in more depth. So I want to kind of, talk a little bit about TA. It can take, as I said, many different forms, and it really should be tailored to each state's individual unique needs, with the goal of supporting new program development and strengthening existing rural training programs. And these are just a number of examples of TA, and we're all going to talk a little bit more about how we approach TA in different states. But some TA centers will focus on rural rotation development. I like to call it capacity building, sharing, just kind of that opportunity for rural hospitals and health centers to really become engaged in GME or even medical student education. It's building capacity so that they can see themselves as a future site for a residency training program. It's also meeting with those sites and helping them see what's possible, maybe doing a feasibility assessment, maybe having a meeting with their physician leaders, their C-suite, to kind of talk about what GME is. In Wisconsin, we'll do like a little GME 101 presentation for those who are interested in GME so that they can kind of explore what's possible. Technical assistance also includes providing accreditation support. Most programs are going to be accredited by the ACGME. There's a few accrediting bodies for fellowships that may not be ACGME accredited, but typically they will be accredited by ACGME, and there's a number of steps and requirements that need to be met. That can be really complex, and it can honestly be overwhelming to a rural hospital that has never ventured into this space before. And that's where TA can help assure that rural hospital or health center that this is possible. There's others who went down this path and have been successful, and will help you get there, even though it may seem challenging or honestly overwhelming. To help with scenario planning, partnerships are usually needed. When you look at developing a program, it's very rare when every single experience is going to be available at one particular site. So many sites are often used, and it's helping those hospitals or health centers see, who may be a good fit, who may be a good partner. What does the financing look like? GME finance is complicated. That could be a 1 or 2 hour talk in a session. Our toolbox, which Emily will share in a little bit, has some resources and connections around GME finance. But because that is complex, that's where TA can be very helpful in just kind of distilling down to a basic level, what some of the different implications may be. And then TA also includes resource and best practice sharing. That can be done through webinars, that can be done through meetings, that can be done through an annual GME summit. And that's usually arranged and coordinated through a TA center entity. Faculty development is also really important as you support these new sites that are establishing GME. To have faculty who are equipped and comfortable teaching and training residents is very important. And TA centers can help with that or help link programs to existing faculty development resources. Additionally, the heart of every program is a program administrator or program coordinator. And many TA centers like ours in Wisconsin, we will focus our efforts on professional development for those program leaders to help them understand requirements, understand marketing, understand how to have good accreditation hygiene. There's a number of different ways that they can be supported. And then it's also a tool to retain them as well once they're really effective in their role. And then, I talked a little bit about educational and networking events. Those are also important. And then marketing and reaching out to medical students is also very important as a TA center to make sure that these programs you're developing are going to fill in the match and that medical students are aware that the programs are in place. So, our research, again, our Millbank brief will be out hopefully within the next month, showcasing, just how TA is being developed and deployed across different states. And states are, using TA in a number of different ways, different capacities. But really, what we found are, kind of the key elements of a successful TA strategy is first flexibility. The services need to be developed to help support both those early stage development efforts as well as ongoing program sustainability. TA that's done effectively also leverages those strong partnerships and has broad participation. Missouri, where Rich leads the new TA center, their last partner meeting had over 80 folks in attendance. So again, really strong partnerships that they have in Missouri. TA centers also offer foundational support, focusing on programming that will support kind of that wide range of needs that programs will have, ranging from development to capacity building to guidance on accreditation and finance. And then most importantly, creating that peer network and collaboration. Our national TA center, there's an annual meeting we hold every year. And I hear time and time again from grantees that, that is where they don't feel alone in this work. And I think that a well-run TA center will bring people together so that they can collaborate and problem solve together and really feel like they're part of a broader community and a broader movement. So again, this is just how states are using TA. And again, we're excited to get that Millbank brief out because we have a whole section on technical assistance. So now we're going to dive into a few different models, and I'm going to start first and then hand it over to Rich, who's going to talk about Missouri. So I'm located in Wisconsin. We have a technical assistance center that was actually established in 2012. It's called the Wisconsin Collaborative for Rural GME, and it was really developed in part because we had 6 rural training tracks that were established in the 1990s, and 5 of those 6 programs closed. And part of the reasons for that were multifactorial. But partly it was because we didn't have a good mechanism in place to support programs that were struggling and to kind of lean in and, provide those resources, when they needed them the most. So as we were kind of regrouping, developing a strategy, the need for technical assistance was established as probably the highest priority, in addition to the funding. TA and funding are absolutely key to get new residency programs launched. But at the same time, while we had those program closures, we do have a wonderful, large academic rural medical center that's been training residents since 1928. So we've had kind of 6 main, rural programs in our state. And again, we identified this need for stable funding, TA, peer networking, and collaboration. So this was when we got started in 2012. There were 13 original partners, including Marshfield, which was our large rural teaching hospital, as well as our 1 remaining rural track program. But then what was really exciting is we started this endeavor, and I'm hoping many of you will be kind of in the same boat. We had 4 interested urban hospitals and 7 interested rural hospitals. So that was just enough to kind of get started and explore what was possible in our state. And again, having a convening entity like WCRGME really helped leverage those available funds to move things forward. Well, I'll share a lot of really great data and information about Wisconsin, and I know this is a slide with a lot of information on it. I really want to emphasize that GME development and TA take time. It takes, like I said, 3 to 4 years to develop a new residency program. So even if you fund a program, say in 2026, you probably won't see residents starting their training in your state until 2029 or 2030, and then they're not going to graduate training until 3 to 4 to 5 years after that. So all of this takes time. It takes time to develop infrastructure. It takes time to develop capacity. And in Wisconsin, we've got some really great results, but we've been at this for over 20 years. So again, keep that in mind. I'm hopeful that many of you, as you launch some of these new efforts, will sustain it even after Rural Health Transformation Fund funding ends, because you can make a pretty significant impact. So what kind of TA do we provide in Wisconsin? I've shared a little bit about our work with you, but really it kind of falls into these, kind of four primary buckets. We really support new program planning. So that is, meeting with folks either before they apply for planning and development grants or just after they receive a grant to talk through all of the nuances of planning a GME program. And we have a really great roadmap in the Rural GME Toolbox, which kind of gives a great timeline to development. But in these meetings, we're talking about finance, we're talking about accreditation, we're talking about scenario planning, we're talking about many other things, but those are probably the things that we talk about right away, as folks are thinking about a new GME program. We're also connecting them with best practice resources and education. This is done through a number of different events and activities throughout the year. We have bi-monthly meetings, we have an annual meeting, and then we also have several trainings for those program administrators to keep them connected and ensure that they're well equipped to proceed in their role. We also do faculty development through a couple of different mechanisms, through a GME Leadership Academy and an annual conference. And then probably in the past few years, a higher priority for us is we're trying to ensure we retain as many medical students as possible from our state. We've really been focused on marketing those rural GME opportunities. So we have a medical student advisory committee. We actually go visit every med school in state once a year, talk to them about our different rural programs that are available. We have a wonderful, YouTube channel, Instagram account, where we connect with those students and make sure that they are aware of the opportunities in Wisconsin. So again, that's kind of the areas that we've focused on primarily. There's many other things that we do, but those are probably the four biggest buckets right now. And then I always get asked the question, is this investment in TA, in infrastructure, is this worth it? Is there a good ROI? And I think that the answer is yes. When you look at the impact of our state funding in Wisconsin, since that initial grouping, if you saw the map earlier, there were 13 partners that were interested in this. Now we have added 30 new programs that have at least 2 months of rural training, as well as we have 9 programs in development. We also do have a grant RFP out currently and are anticipating, at least 3 grant applications will be received for that. So that number of programs in development will go up from 9 to hopefully around 12 or more, and we'll see additional growth and additional programs. I think what's also really neat is that in Wisconsin, because of all of this effort we've, kind of implemented to grow different specialties, to grow statewide, we have a number of different programs that have launched, ranging from family medicine to internal medicine, OB-GYN, psychiatry, and surgery. And then we've had a number of really great fellowships that have also grown and expanded. We obviously have work to do in the northern part of the state. That's probably where our biggest effort and attention has been over the past few years, but it is really neat to see the impact of this funding and what it's been able to achieve. And collectively, as you'll see on the next slide, this accounts for over 300 additional positions that have been created once those programs get to their full complement. It's actually 308 right now, new GME positions that we've been able to create. And of those 308, about 20% are funded by state dollars, and then 80% of those are funded by Medicare funding. So again, ensuring that whenever possible, we're able to get that sustainable Medicare funding, as Emily noted. That's obviously the first choice, but if there's just not a path forward, then we're looking at what we can do around state dollars to, continue to grow our GME presence. And again, this accounts for 100 new physicians each year entering programs in a mix of different specialties, primarily family medicine, but we are really thrilled with the number of programs who've grown in surgery, psychiatry, OB/GYN, internal medicine, and others. Of our programs, 39 programs will have over 2 months of rural training. Most programs are probably in that 12 to 18 to 24 month range, but there are a few where it is harder to get, those rural training months and still meet specialty requirements. And the impact of this, we're really excited to share that 21% of our residents across all specialties in our state train for at least 2 months rural. And we've been able to retain about 70% of those graduates in our state. And right around 60 to 65% of those grads are practicing rural. And again, we've been able to get increased state support for these efforts. Currently, the planning and development grants are $1 million, and that's for a 5-year planning period. And then the expansion grants are funded at $150,000 per position, and that's done through Medicaid GME. So we're really excited about the work that we've done and just what we've been able to accomplish. And I am so thrilled to hand it off to Rich LaBaere, who is going to talk a little bit about the great work being done in Missouri to really grow their workforce and develop, I think, a pretty comprehensive strategy.
Well, thank you, Lori, and thank you, Emily, for inviting me. Missouri's strategy really has been driven by the acknowledgement of data and then the acknowledgement of seeing how that support is necessary. So our state graduates about 1,100 students each year, 9th in the country, but there's only 840 first-year slots. So we're an exporter. So and by looking at our needs assessment within the state of the types of physicians to man our workforce, knowing that specifically in rural areas, primary care, psychiatry are those areas where we need to put the biggest amount of our energy in terms of anticipating the shortages that we have today growing. So how do you do that? Now, you've heard the themes in terms of stakeholders and making sure that we do this together. So having an advisory committee that helps us coordinate, and this is central to our strategy. It is getting the viewpoints of hospitals, medical schools, residencies, DIOs, program directors, FQHCs, and our multiple physician and medical associations is key. So our growth related to the data showing where our gaps are really directed us to investing in areas like family medicine, internal medicine, psychiatry, OB/GYN, and pediatrics. So this roadmap in a completed needs assessment, convening people, bringing people together, and educating was the first step. So we've heard about the Technical Assistance Center, and I think that in many ways the Technical Assistance Center is both a foundation and it's the glue to the process. So however it is that you invest in new GME development to address workforce challenges, using the Technical Assistance Center to find out information at each place along the pipeline is essential. We've heard how we understand in the context with medical students, existing residencies, and then creating both funding opportunities. So funding opportunities for in places that are considering feasibility. Could we do this? What are the scenarios? Support for new program development. Yes, it's feasible. We need resources for that program development. That's been very successful in states like Wisconsin. And then curriculum enrichment. So how do you take the resources to actually meet the needs of our particular state? A nice way to jumpstart is the early funding to expand existing programs. It takes a lot of effort and energy to start from the ground level, but let's jumpstart and address those needs earlier. And so technical assistance really starts with helping programs that are existing, maybe expand, help development of new programs, and also maybe assist those who are struggling. So you can see with our long-term projections, by FY36, our goal is to have over 1,000 new GME positions and averaging 150 new residents entering our pipeline and keeping them at 87%, Lori. So a little bit better than Wisconsin. But our goal is to grow them, sustain the programs, and keep them. So what are those early outcomes? So, I mean, this is the real deal. Altogether, there are 25 new individual residents in our state with the slot expansion. And you can see the focus, family medicine, internal medicine, psych, OB-GYN, pediatrics, and family medicine. Like that's a jumpstart. This is where the outcomes are, that we grow them according to our need, that they stay. Okay, so how does the Technical Assistance Center operate? So there's an infrastructure, there is a framework, and then it's that direct GME program development and support at all places along the pipeline, even starting in high school, undergraduate, into medical schools and residency. So getting direction from the advisory committee for strategy, and then assessing, how do we improve? Are we meeting those marks? Great examples that Lori shared with regard to some of the outcomes over the years. So our initial focus has been with new program development, and these are grants. So you can see there are 6 different organizations who are developing new programs. So these are programs in that pipeline of developing. I can tell you that at least a couple of those are going to be in the match for the first time. So these are matching new residents, new physicians we're going to keep. But, family medicine, psychiatry, internal medicine, and family medicine with OB. These are in the pipeline developing that 3 years to develop, 3 years of training to have that outcome. Feasibility, kicking the tires, can we do it? And then the curriculum enhancement, that exposure. If you want residents to stay and train in rural areas, they have to have an exposure. So let's create that exposure. The little sign that you see that is the reminder, 1,000 new physicians that is a mantra. And I think it's it's a motto, it's a mantra. You have to keep that in front of people. This is why we're doing it. We're doing this so our neighbors and our families get the access to the care they need. 1,000 new physicians over the next 10 years. Okay, so what are those main systems? All right, let's start with those recent grantees, as I mentioned. And what are the things we do? What do they need? Some people need a whole lot. Okay, let's help them with their developing their programs. Some programs have lots of internal support. Okay, then we're helping them specifically with their unique needs and achieving their mission. But providing resources for policies, application support, the DIO program director, reviewing applications, helping get started, and having some finance or accreditation consultation available. This is, once you're in it, we are going to walk with you arm in arm. Okay. So then there's the other part of the pipeline, and that is outreach to hospitals and healthcare centers to consider this. How can we grow what to help make this needs? The northern part of Wisconsin is Lori's work. The northern part of Missouri is the same deal. And so explore feasibility, educate about the value, really talk about what is graduate medical education. What would it take for you to move into exploring the feasibility of program development? So let's consider and get those stakeholders involved. But it's helping people take that next step. So how else do we do this? Well, it's working with our collaborators, and our collaborators get information from these every 2 month stakeholder meetings, the creation of and support of program director forums and educating DIOs, one-on-one outreach actually, and these partner education sessions, helping them. It's really tilling the soil so that when there's a grant opportunity, you plant the seed, it can grow. So education is tilling the soil. Newsletters, this educational summit that we're doing, that's coming, our second one, and then supporting our advisory committee, supporting so they can give us direction. And you can't do it without data about medical students, data about our capacity. We have a session coming up, which is like, let's learn what are medical students looking for? What's important? What are we doing in the state to keep and develop and cultivate our students to stay here? But what are they looking for? So the information goes two directions. What's our capacity and our baseline and growing, and specifically think about our workforce and where is the greatest needs? Our stakeholders give us direction. So really, it's also helping existing programs explore feasibility. So some programs can grow, getting some outside eyes. And you can see in this picture at the bottom, these are our members of our advisory council. I love reminding ourselves this work we do has an impact on our neighbors and our patients. These are patients of mine. You know, always keep in mind that this work, though great and complicated, can be done when we work together and take advantage of resources. I will go ahead and pass it over to Emily. Oh, last slide here. Funding, what's new in 2026 to 27? 3 different types of grants, new program development. Okay, new program, you're ready to develop. You need seed money to get started, up to $333,000 per year, up to 3 years. You can see the eligible programs. Expand rural programs that you already have. Okay, once again, this is targeted specifically for the needs and the strategy for Missouri. Feasibility assessment. You know, can you do this? What are some ways? What are the finances? Do we have the internal resources? Okay, how could we partner with others? And then enhancing that curriculum. How can I give the injection, the booster shot of rural training to maybe spark that fire that then maybe keeps them in our area and talk about and educate around addiction. So now I'll pass it over to Emily.
Thank you, Dr. LaBaere and Lori. So now I'm going to shift to sharing about North Carolina and then also some resources that we want you to have at your fingertips as you're working in your states. So our North Carolina GME Technical Assistance Center was really built on, which has only been in existence for about a year, built on this robust data infrastructure led by Aaron Freyer, who has been studying the healthcare workforce of North Carolina for 25 plus years, utilizing licensure data, as well as her research and policy expertise. And so we're really fortunate and grateful for that backbone. And also want to acknowledge the important North Carolina AHEC funding that made some of this work possible. So why the recent emphasis and funding for GME development and technical assistance in North Carolina? And I think the answer to this in short is that our legislature became very familiar with this picture on your slide, which shows the growing gap in physicians practicing in rural areas compared to urban areas. And that really is our mission and the impetus of why we're doing this work. In fact, Erin and her team found that of the physicians graduating in 2017, 2018, and 2019 from a North Carolina residency who also graduated from a North Carolina medical school, that almost 65% were still practicing within North Carolina, but only 4.8% were actually practicing in rural areas in our state, as you can see in the green on this chart. You know, as she recently published this data, my thought was this is actually not surprising to me because our TAA Center has quantified that only 4% of GME positions in North Carolina are actually located in rural areas. And like Lori mentioned, we know that physicians who train in rural are more likely, 2 to 5 times more likely to practice in rural. So we don't have enough positions in rural areas. So as a starting place over the past year, as we've been establishing this new GME TA Center, we mapped out the distribution of physicians by specialty and looked at the existing training sites of each of those specialties as really just a benchmark and a guide for us. So green in these maps represents the higher supply of the physician type. So in this case, it's general surgeons. The dots represent the existing training sites within our state. And you can see at the bottom in the small text, 25 counties in North Carolina do not have a general surgeon. That's a problem, and clearly we need to address it. And so I'm so grateful for is that we're really intentionally using data to guide our workforce planning, not only for funding allocation, but also for proactive outreach to really build capacity in rural settings as well as unreached settings that have never had training before. One of our also baseline starting points was to say, let's take time to see what has worked and celebrate the successes of our state. So for the specialty of family medicine, we have a lot more green. Look at that, especially on that left side of our state in Western North Carolina. And I really want to acknowledge MAHEC. They have made it a mission, and I love Brian Hodge when he says this. He says, we have made it a mission to eliminate health profession shortage areas in Western North Carolina. And that spans not just physicians, but it's multiple disciplines and specialties. And you can see from family medicine, this has taken a lot of years of hard work, but we're seeing more green. And our hope is that we see green span all these different specialties and team-based professionals throughout our rural areas in our state. So much of this expansion in rural and underserved training in our state is really because of the infusion of federal startup as funding as well as sustainability funding. And I want to kind of just share with you these two figures. So one of the first steps we looked at is how many programs do we have in rural? We have 10 rural programs in our state, 165 positions, GME positions of the 3,700 total GME positions in North Carolina. And you can see on this top figure, we looked at programs with rural sites in green and those with health centers in blue. And you can see that there's just been this increase since 2010. And interestingly, the bottom graph shows that infusion of federal grants for GME. And so we see that similar line. When we see this increase of federal funding, we also see this growth of rural and underserved training within our state. But unfortunately, there's limited federal funding. And so what you've seen as you've seen the outcomes in Wisconsin is that state funding can really augment federal funding and make a bigger impact for each of your communities, regions, and states. So we've been very excited because we were connected with the UNC system. Aaron Freyer connected us with the UNC system, which really spans our entire state. And they said, hey, we want to address physician workforce shortages. Can you help us? And so we worked together. Lori was engaged in this too. We helped craft and deploy a grant program in partnership with the UNC system that builds on the existing successes within North Carolina and also what we've seen nationally. So you can see here we have, there's 8 million recurring. There's also some non-recurring funds that are being used as well. But there's 4 grant types, and they look very similar to what Lori and Rich, but each state needs their own flavor as well. And it's important that you have an advisory board that really is guiding those programs and that funding. And so we have a development category to start new accredited programs, whether through a complement increase or a brand new separately accredited program. We have sustainability grants that are really for programs that don't get, based on our research, equitable Medicare funding, like Soul Community Hospitals, expansion grants that fund positions for programs that have greater capacity for training, but are past their cap building period for 5 years. The other one, which we're really excited about, is Innovation Grant, which are really to grow rural fellowships that help with retention, as well as interprofessional rural training opportunities that demonstrate rural retention. I won't go through all of this because it really mirrors what Rich and Lori have shared. We have technical assistance services that span new program development, a lot on GME financing, support for the glue that holds all these programs together, our administrators, informational meetings, webinars, workshops, annual convenings. I do want to draw your attention and just highlight something that we've seen, really be an important role for TA is financing and accreditation. It would be a disservice, and really a large portion of why we wanted to get in front of you today as you're working with your states is that it is critical to ensure that you build programs that sustain long term and that you use those stable sources of funding like entitled Medicare funding when you are crafting your program. And it takes a lot of expertise in doing that. And so what we have formulated as vetted consultants, we've actually now incorporated, because of our lessons learned, mandated consulting for financing, just to have, one of our trusted consultants have a second eye. Even if it's a really seasoned sponsor, we still kind of require that. And just want to make sure that in that feasibility and scenario planning, we're saying, hey, have you thought about Section 126 funding for Medicare? Have you thought about, if you considered a partnership with this training site that's in a non-metropolitan county, you're at 42% rural training. What if you increase that to 50%, you could get Medicare funding. So it's really getting into the weeds and helping them form the program that is built and designed for their community, but in light of long-term sustainability. The other thing that we've found a lot of success in, too, is doing accreditation consulting too. So doing those mock site visits to prep for ACGME site visits, as well as being the second eyes and a reviewer, copy editing and reviewing their accreditation applications. So most of what we have built is, we'll cover kind of some of our national tools, but I want to highlight that most of what we have spent our past year doing is really a lot of scenario planning and feasibility assessments. And so our deputy director, Mary Alice Scott, actually created, with feedback from a lot of folks, led the development of this readiness assessment tool. I included the hyperlink for you, encourage you to access. I think it's fantastic. And so what it is, it's really looking at sites and partners and saying, how can we build capacity with those that are currently interested in participating, but also maybe recruiting brand new sites that have never engaged. And so this is a helpful tool that we want others to utilize. And I'm really grateful for all the hours that she spent in partnering and meeting with these different sites. And we're proud to say that there were over 30 applicants for our recent first launch of our grant program, which is wonderful with this new initiative. So now what I want to shift to is our national kind of rural GME tools and resources. What I'm going to highlight is a few of our favorite tools and resources that any of you can access at www.ruralgme.org. So this is a picture of our toolbox. You sign up for an account in our portal. Our tools are organized under the categories of community engagement, program design, financing, institutional sponsorship, program accreditation, and then program implementation. If you click that View All Tools, you can filter tools by various kind of categories, and there's a free text option, which is my personal favorite. I highly recommend a couple of tools right now. You can search what's new in GME financing. It's a great resource. And GME Financing 101. Those are good places if you're saying, hey, how can we make sure that we're built for long-term success? The other tool I wanted to highlight is our roadmap, which Lori and Rich have alluded to. It delineates the stages and milestones of development. And I think it's important for you to know that this has actually been deployed and implemented with over 100 grant recipients. And I think someone on our team could correct me, but over 40 different states. And so I think it's something that is tried and true that we've been doing and deploying since 2018. Encourage you to check this out and use this as a resource as you're walking folks through the process of attaining an accredited, financially sustainable residency. The great thing about the roadmap, it connects and feeds into what's called our progress tracker, which is used to really guide grant recipients in their development. Each grant recipient is assigned an advisor that they meet with quarterly that really coach them through the development phase. And the intent of this is really to guide them each quarter on what they can focus on next to make it a little bit more digestible than telling you all the all the 160 things that you need to do over a 3 to 5 year period. I also want to draw your attention that we do have, a section for training sites to capture all of those. And then we importantly have residents. So capturing those outcomes are really important for policymakers and stakeholders. Our hospital analyzer is our most accessed and probably our most important tool that I could leave you with today. Thanks to the the amazing expertise of Mark Holmes, who's on our team. He also runs HRSA's Rural Health Research Center at UNC Sheps. And he, along with some of our wonderful PhD students, have worked to create this hospital analyzer that has a report for each hospital in the US. And as we've shared, Medicare reimbursement is complicated. It can be impacted by your hospital type, your location, your specialty. We've recently new data with this, so encourage you to check it out and really kind of begin to have more of a starting point and a framework to work from for scenario planning as you're considering GME expansion. We also collaborated with CMS and HRSA on the glossary, and so we are in the works of getting that finalized. We should have it edited and uploaded in the next week or two, but encourage you to check that out. The other thing, as you're looking macro, as you're looking at your state and saying, who should we consider partnering with? We want to provide as much information and tools as possible because there are so many wonderful potential opportunities for growing rural in your state. And so one of the things we did is look at all GME naive. So that means those that have never participated in training. We also call them never claimers, and identified those GME naive hospitals that are in rural areas that seem to look like teaching hospitals based on their financial characteristics. And so we're calling them prime rural hospitals. This is a picture of how you can access it on our toolbox, and it's really used to guide statewide TA efforts. And what's been really fun is to actually have some of these prime rural hospitals become rural residency planning and development grant recipients. And a couple of them have shared this was just a catalyst for our board to hear this, and it gave us just another kind of icing on the cake to be able to take that next step in GME development. So we want it to be helpful, but obviously there's a lot of factors that go into starting a new program, not just financing. The other tool that we actually created last week is in response to kind of a HRSA request is that partnering with hospitals that have never claimed GME costs can be a strong path for Medicare reimbursement. And so Mukesh Adhikari, our research investigator, last week ran the data and we created this list of never claimer hospitals that you can consider filtering by your state and looking to consider kind of outreach and capacity building for partnerships with training. Finding rural residencies is important for multiple audiences, including medical students, training site partners within your state, as well as, or even across the border at neighboring states, as well as policymakers. And so we've created this map that's available at the link that's on our website through our TAC data, as well as our agreement with ACGME, which we're super thankful for. So I encourage you to check that out. The real success hinges on relationships. It's those intangible benefits of building a community among people that are like-minded, that are in similar situations, that understand your challenges and also your mission, right? And so I can't say enough. I wish we could spend the whole hour talking about building a community because that's what Dr. LaBaere, Lori, and I have seen both nationally and at the state level, that it is about relationships. How we formulate relationships can be different across states. We have webinars, workshops. I do want to draw your attention to something that's available to your states, which is we have led by the Lori's team at WCRGME. We have a rural administrators network that's national that you are welcome to kind of engage administrators in. We have a health center administrators network that's also open to those health centers engaged in training. We also just partnered with ACGME to launch a health center DIO network, designated institutional official. Really excited about the support that is coming through that. So not only do we have these, and I do want to say that part of, and I think Rich alluded to this too, that part of why this webinars and this information sharing is really important is because a lot changes fast in GME. And so part of what we need to do at a TA level is make sure that everyone across the state understand the latest information on policy and regulations. And so we've been thankful to really be that voice at a national level for the Rural Residency Planning and Development Program, and are really thankful that several of our grantees have accessed federal funding like right at the beginning, right? With the Consolidated Appropriations Act of Section 126, a couple of our grantees were the first rural track programs in the nation. And so part of that happened because we're saying, hey, here's the latest. We're reading the regulations and policies. And so I think it's really, really important to be that place, that trusted place that also is really up to speed on the latest regulations and policies. Um, the other thing that I found really helpful in convening folks is that it helps generate innovative and creative ideas. So not only are you problem solving, but you're really kind of supporting each other with best practices and idea generation. We also have found that community building is not only those virtual meetings and the annual convenings, but it's also like on the left bottom slide, it's about site visits, going out there going to the communities, seeing what's going on in the ground. And really kind of it illuminates not only the successes and stories, but also the challenges of what's going on. And then finally, it's communities with not just similar programs, but stakeholders and national and state partners. And so this is a picture of Lori at the legislature. They have had such bipartisan support and have really been engaged with their stakeholders. I also wanted to bring your attention to that picture on the top, which is probably my favorite picture from our annual meeting, and that is the ACGME supporting one of the grant recipients. And so it really has been national partners, state partners, all coming together to say, hey, how can we support you in this meaningful work? And then last but not least, because we're almost out of time, I want to say communicating the impact, dissemination of that impact is really, really important. And that can happen through videos. I encourage you to check out the YouTube channels, doing reports to the legislature, testimonials to the legislature, as well as published articles and local news articles. Those stories make a difference, and we have seen a lot of wonderful work through marketing videos of the impact on the ground. And this comprehensive TA approach is important for not only building new GME capacity within your state, but ensuring that this GME capacity does not go wasted, that it sustains long term. And so we've had a lot of great outcomes with HRSA's rural residency program and are just grateful for the opportunity today to share about it. We'll be discussing a lot more details on state GME strategies at our state GME summit, which is March 18th from 12 to 3 Eastern. Encourage you to register for that with the QR code. And with that, I'm going to turn it over to McKenna for any last follow-up items.
Thank you, Emily. Yeah, if everyone could just register if you're interested in attending our state GME summit. It is going to be held March 18th, as Emily said, from 12 to 3 p.m. Eastern time. It's virtual, it's free. We'll be disseminating an agenda shortly. So if you're even just interested in coming for a couple different sessions, we'd love to have you there. This presentation is recorded and will be shared after. Thank you, Shelby, for moving my slides forward. If you're interested in joining our listserv to receive the slides and recording, you can go ahead and send us an email at info@ruralgme.org or info@thcgme.org. Yeah, thank you all for joining us again today.
Wonderful. And do we have time for one or two questions, I'm wondering, or comments?
Yeah, we have a couple of minutes left. If anyone wants to come off mute, feel free to unmute yourself and ask your question or put it in the chat.
I'm glad you found this inspiring, Liz. We want you to be encouraged and motivated to do this. It makes a difference, and it's worth the hard work. So please reach out if we can be helpful. Lori, any closing thoughts from you?
I mean, I would say, this work is just so rewarding. Being on the TA center side of things and seeing programs, in this kind of dream state of we want to do this to the actualization of training residents and then seeing those residents stay in the community. And I just think about a recent meeting, that we had with WCR GME, where one of our hospitals was so proud. They had 4 graduates of their rural track program, and all 4 were staying in state, and 3 were staying within the local community where the hospital was located. So I think the message is this works. It's worth the time, the investment, the energy to go through this process of launching a program, because you'll see the impact with workforce. And again, that is made possible through TA and supporting programs every step of the way, even when they encounter inevitable obstacles. They're obstacles that we've seen before. They can typically be overcome. There's always, I like to believe there's always a path forward. So, just helping them see what's possible. So those would be my thoughts. Rich, I don't know if you have anything to share.
I agree. It's making the calls, reaching out. There are people who have kind of walked down that pathway, and just being able to bounce ideas off of and maybe look at it a different way. And this journey works best when you just start taking the steps.
Well, and I'll close with one last phrase. I'm going to copy what Rich said, which is having different viewpoints is important. And so we are stronger together. Partnerships are key, which is why we wanted to share our lessons learned and hope this is a helpful guide to you. Please access the recording in our toolbox and join our listservs. Email us at our inbox. We want to help you.